Good afternoon, and welcome to another Research in Action, brought to you by the Division of Research at Florida Atlantic University. My name is Karen Scapinato. I will be the moderator of today's session. With that, it is my very great pleasure to introduce our today's speaker, Dr. Ruth Tappen. She works on a number of Alzheimer's-related issues such as communication, exercise, caregiver stress, cultural bias, and most recently, driving with memory disorders. With that, I'm going to turn it over to Dr. Tappen.
Okay, hello everyone. I'm going to talk about memory disorders during a global pandemic. So what I'm going to be telling you is probably only the first half of this story. If you ask me how people with memory disorders have fared during the pandemic, I will tell you they have not fared well. There are approximately 50,000 COVID-19 deaths in U.S. nursing homes. This is 1/4 of the total deaths in the United States. This, you all heard the early stories about some nursing homes where almost became petri dishes, where they had staff and they had residents who developed the coronavirus and died in relatively large numbers. CMS, the Centers for Medicare and Medicaid, swooped down on them, and fortunately, the situation, I think, has stabilized some. But the loss of people in nursing homes was declared one of the worst disasters of the pandemic by the World Health Organization. They made some pretty stern comments about what's happened in the nursing homes, and they called the lack of concern about older people in nursing homes moral bankruptcy, which is very strong terms. Interesting that people from Doctors Without Borders actually came to the US to help, and they said it was surreal. They usually see themselves as heading out to third world countries, and in this case they said they had to come here and teach people how to get a pandemic under control. From inside the nursing homes, they were completely overwhelmed, and their staff were really frightened. And from some family members who lost people, they said, she didn't deserve to die like this, and it hurts my heart how he died, talking about a family member. Let's just briefly review Alzheimer's disease before we go into some more detail about what's happened to people with Alzheimer's and related dementias. It's a degenerative disease. It usually hits in later life that damages and eventually destroys neurons involved in thinking, learning, and memory. Eventually, the person who develops Alzheimer's is unable to manage even their own basic activities of living, which are taking care of yourself, feeding yourself, toileting yourself, dressing yourself, things we do every day and never even think about. The progression of Alzheimer's disease is like a tornado. The majority of older people are there at the bottom. They have maybe some age-related changes of cognition, some occasional problems, and they're self-correcting. They know they're having a problem. They do not have Alzheimer's disease. The people with mild cognitive impairment, MCI, have very subtle signs, primarily of memory and some minor difficulties. As a matter of fact, sometimes they're not even really very aware of it. Again, this is not Alzheimer's, and about half of the people with MCI will convert to Alzheimer's disease. Early stage AD, still, the people can remain relatively independent. They may need help with new complex tasks. One of the more recent problems is with new software. It used to be balancing your checkbook, but now it's learning new software. People in the early stages are really, they can be easily overwhelmed. Moderate AD, okay, we really have a much more serious problem here. And severe, routine tests become difficult and the people need help. With severe AD, they're barely able to manage. Many of them cannot get out of bed on their own, and they really can't take care of themselves. So you can see that this is a vicious disease. This can take 10 to 15 years, by the way, to develop. These are sad pictures of a brain. There's on the left a healthy one, and then a brain with advanced Alzheimer's, you can see the fissures have widened, and you can see the healthy brain behind the diseased brain, and it really literally shrinks. This is also, you see a healthy nerve cell on your left and one that's been affected with plaques and tangles that are a hallmark of Alzheimer's disease. The synapses, the nerve cells, become virtually non-functional. So how people can think with nerve cells like that, you can imagine it becomes very, very difficult. The numbers of people, as we have been able to control other diseases of older age, are going up, up, up. This is an impressive graph of the Alzheimer's Association. You can see the number of people over 65 today who have it is about almost 6 million. By 2025, which is only 5 years from now, 7 million. But by 2050, we are climbing a slope there, and it particularly hits people over age 85, as you can see the people in the purple. I'm not going to go into any of the detail on this slide, except to point out the numbers in the circles at the bottom, the red circles, that people without Alzheimer's or related dementia, their annual costs are so much lower than people with dementia. They are a major cost to our healthcare system, and we all sure wish we could get some new drugs on the market that can do more for people. There are some, but they don't have they're not very powerful yet. And we've been waiting a long time for their development. Drugs that are used are mostly ones that have been around for a while. They really, really also become one of the major customers of long-term care services. Look at this. 1/3 of the people who use home health services have Alzheimer's, and 1/3 of the people in adult day services also have Alzheimer's. 42% of residential care facilities do, and virtually half of nursing home residents have Alzheimer's, which is why I've been focusing and will focus the first part of this on what has happened in the nursing homes. That most of the people with AD in nursing homes are long stay. They can stay for 2, 3. I've actually seen people who've been in a nursing home for as long as 10 years. The short stay people are people who are in and out. And today's nursing home has a lot of short stay people who don't have dementia. They're there for rehab. As a matter of fact, some of the people on this call, on this web program, probably either have gone for rehab in a long-term care facility now, or have a friend or family member who has done that. 75% of people over 80 with Alzheimer's disease are admitted to a nursing home. 3/4 of it is just a huge, huge number. And it's because they really get to the point where they cannot take care of themselves. So what happens, or what has happened in long-term care? The latest data that I could find from CMS is mid-August of this year. And at that point, they had tallied 49,871 cases. That is out of the current numbers, about 190,000 deaths in the US. So that is 1/4 or more of all of the deaths are these people, and half of those are people with Alzheimer's. So you can see they have been at very, very high risk. I think we are always interested in our local experience, our local perspective. And you can see here that we don't have the highest number of cases. We're not in that deep, deep red, but we're in that deep orange, the state of Florida. And right above us, look at the whole South. We have quite a problem, and yet we have other parts of the country where they have effectively controlled it faster than we have, and have a much lower number of cases. The pattern for the deaths is almost the same, although the state of Washington comes out again. And you can see, and we also have very, very high numbers in the Northeast, in New York, Pennsylvania, New Jersey, where we had our first major outbreaks of COVID. Well, CMS has really tried to keep on top of this, although I had to laugh a little bit about what they called this. This is their final rule, but they're calling it their interim final rule because we know it's probably going to change again. They have been moving with the disease. They have been moving with what we're learning about it. And so their rules concern testing of residents and anybody else who comes into the facility. They have a new detailed survey tool. It's pages and pages long to assess, that's not access, to assess compliance. And they have rules for daily screening of residents and screening every shift for staff. Look at this complicated, and it does get even more complicated. If you look at the bottom, you can see that some of this is based on the positivity rate in the community. So their testing frequency is only once a month in those places where their positivity rate is under 5%. Then we have the medium, the 5 to 10% once a week, and the high positive rate communities. Twice a week, they expect the testing to be done. Any staff that have any signs and symptoms have to be tested, as do residents. Outbreaks, if there's an outbreak, new cases arise in the facility, they want everybody tested, even those that were negative, and they want retesting every 3 to 7 days until there are no new cases for 14 days. And routine testing, they're basing that on the positivity rate in the community, and they're not recommending it for residents at this time. Yes, this is what they're sharing. I was on a CDC, this is from CDC, not CMS, but they're working together on this. This is what they were talking about. And the questions on that hour-long call were constant, looking for clarification. They were all about the facilities and the people who work with them, the people who consult with them. There's a group called the QIOs, Quality Improvement Organizations, who are funded by CMS to help nursing homes raise the level of quality and meet requirements. They have focused almost 100% on control of COVID. And the nursing homes are really having trouble figuring out what they do under what circumstances. So there are some options on testing. There is point of care testing, which has a very rapid turnaround, and which means that you could respond very quickly, but it's presumptive at this point. Then we have the RT-PCR, which is confirmative, and that's a little bit harder for them to do. I think in the previous one, let's see, you can see at the bottom there, the requirement is that they get results within 48 hours, and in some locales, they still aren't able to do that. So then they have to use the point of care test. The first 2 antigen tests approved range in sensitivity from 84 to 97% when used within 5 days of symptom onset. So it's not 100%, but people who don't know much about lab tests are the only ones who expect that any test is going to be 100% accurate. Still, it does mean that we're going to miss some people, even with this pretty rigorous testing that's going on in long-term care now. They also have a set of guidelines for healthcare settings, particularly healthcare settings in the community, and you're going to find these are familiar if you've had a physician visit, even a veterinarian visit. The veterinarians are following this too. If the person who comes in the door has COVID symptoms, you either reschedule if it's routine care, or you have to follow triage procedures. If they don't have any symptoms, then face coverings are required. Hand hygiene, of course. And the recommendation, does this sound familiar? Limit and monitor points of entry. For a very long time here in Florida, no one was allowed in any long-term care facility. And I'm going to get to those slides in a minute. And they recommend they establish a screening station outside the facility. They want everyone screened, temperatures, reports of any exposure, and any symptoms. And cohorting has become a very, very important part of how long-term care facilities are managed. Well, this was a week ago out of the Broward County Sun Sentinel. The reaction of South Florida nursing home operators to all of those new rules that I shared with you very briefly is that they're impossible to meet. They really are overwhelmed. I don't think in this case they're just getting their back up. I think they're really, really finding it hard to catch up with infection control. Nursing homes have not been as active as hospitals in infection control. They haven't had to be. Many of these facilities did not have somebody designated as an infection control staff member. Often it was just the director of nurses who was supposed to take that on, as well as a whole lot of other responsibilities. I don't think we're going to see that again. I think we're going to see real infection control. We really need to. This is why it took the nursing home so long to get up to speed on the COVID testing and on COVID control, which was most important. Well, let's look a little bit. We've been talking at the facility level mostly. Let's look a little bit at what's been happening at the individual level. Finally, the governor of our state issued an order, which is the next slide. He said he weighed the risks of isolation against the risks of infection and decided to lift visitor restrictions. They had been in place for 6 months. And it caused quite an uproar because families just came to the nursing homes. A lot of families came to the nursing homes and they were turned away. They were said, we are not ready. We don't have procedures, policies, and all of those controls, those that I listed earlier, we don't have them in place yet. They said, we need some time to get our policies in place so that we can do it safely. There's a picture of somebody visiting through the window, and we'll get to that. Okay, well, there were a lot of different opinions about the lifting of that order. Of course, families were relieved. They've been waiting 6 months to actually see their family member. Can you imagine? It's been really, really hard. It's been very, very hard on both sides. And I'll point your attention to the comment at the bottom. I want to see my father who has AD while he still knows me. But another family member said if they open too soon and we bring that virus in, it would be devastating to all of the people, the staff, and the residents of those facilities. What did the nursing home say? They said we needed time to communicate with our families. They wanted to let their families know what the rules were going to be and when they were going to be able to accommodate them. You can't just open your doors. You've got to follow all of those routines for making sure that you're not letting people in who are infectious, not just symptomatic, infectious. And the criticism of the facilities was that they knew this was coming and they should have been prepared. Why are visitors so important? I'm going to tell you that, particularly for a person with dementia, visitors are very, very important to them. And perhaps one of the ones that you may not have thought of is that they act as an advocate for the resident. They know what the resident needs. They know the resident as a person from before they develop this dementia. They know what their likes and dislikes are. They know what's important to them. They know, for instance, their allergies. That's one of the things that's come up. Staff may not know all the little details that family members do. And family members come and visit and they act as an advocate, a spokesperson for the resident, especially the one with advanced dementia. They help connect people in these facilities to the outside world, especially when they're locked in like they've been. They provide some social stimulation, which is really important medicine. And they do little things, important, meaningful, but small gestures and little bits of help. Staff simply cannot provide. Nursing homes are not well staffed. The number of minutes a day that a registered nurse is required to spend with each resident is really, really very small. So how does dementia interact with these pandemic challenges? Oh, you know, it relates to the disease, and that's why I reviewed what the problems with the disease were. It's way, way more difficult for a person with dementia to remember about social distancing. They forget. They don't learn new. They particularly don't learn new information very easily, and this is abstract to them. Mask use. Masks, for most of us, are annoying, so we take them off when we can. A person with dementia is likely to just remove it because it's annoying, even though it's not appropriate for them to do it at the time. Hand washing rules. Again, they need supervision and reminders. But there's other things going on. Look at the picture of the staff member with a mask and gloves on. Well, it's very difficult for a person with dementia to recognize who that masked person is. I know that we're talking about a different species, but at the veterinarian offices, they had very, very upset dogs because the dogs thought all the people, they were strange. They didn't recognize any of them. They barked and barked and barked at people with masks. And I wonder if in some ways people with dementia just kept looking and what, you know, I feel like I'm in an alien world where everybody has their face covered. So they don't understand the new rules, especially in advanced dementia. They're not able to judge how long it's been since somebody came to visit them. And so the isolation is acute for them. Another thing, nursing homes have very quickly adapted to technology-assisted communication with families. But people with dementia have not really understood who they were talking to when they were looking at a tablet, an iPad, as you see in this picture. They don't necessarily recognize the person because they're seeing him in a different way. And understand we've got somebody with impaired thinking. People have been so isolated because of the pandemic. Doors to resident rooms now are mostly closed. Depression has increased enormously in the community and in our residents. There are some other unanticipated problems in that a person with Alzheimer's in particular may not remember whether or not they had a meal. They may not be too aware of how thirsty they are. They need encouragement to eat and to drink, and less of it is happening apparently. Okay, reports from the field. I don't know if you can find this data yet, but this is reports of what people are seeing and some of the data that's coming in. They're seeing higher incidence of urinary tract infections in the nursing homes now. An increase in pressure ulcers. Why? Because people are in bed more, they're isolated, they're limited to their rooms. The day centers are, the dining rooms are closed. They're not having communal dining. The day rooms are closed. People are kept in their rooms most of the time. There's staff are given a whole lot of extra responsibility for infection control, and so they're not able to get into the residents' room, so we're seeing increased loss of bowel and bladder control. Decreases in activities of daily living. Those are those basic things we don't think about: taking care of yourself, feeding yourself, getting dressed in the morning, getting bathed. There's decreases, and increased use of antipsychotics. I cannot tell you how much time, if you're not familiar with long-term care, has been spent by CMS and other groups trying to reduce the use of antipsychotics in people with dementia. For the most part, they're not appropriate. The people with dementia aren't psychotic. That's not the problem. And these antipsychotics are very, very hard on them. They have a lot of adverse effects, and they really have made major, major efforts to almost eliminate them, almost down to zero, and now they're back up again. So we have lost ground in all of these right here. So there's a typical dining room in a nursing home, and it's empty. And they're going to stay that way for a while yet. So nursing homes have made quite a few accommodations. One is they've learned to cohort, and so they put all the COVID positive residents in one wing of the nursing home and the negative people in another wing, and try to keep them separate. They have an observation unit. Typically now when somebody is admitted to a nursing home, they are in their room and under observation for the first 14 days of their stay. Difficult for people who are a little bit confused to begin with. They don't understand why they're locked in. Kind of sad, maybe heartbreaking. I think the staff in some of these places said it's been very, very difficult when they have people who are dying. And so these facilities, when they can, have set up special rooms, single rooms, where the dying resident can be taken care of and where family can come in and spend some time. And I'm glad they're able to do that. But then there's some more isolation for the resident when the family's not there. But I think it's a good accommodation, and they've tried very hard. At first, they really weren't training their laundry people, their dietary people, their environmental service people. And then they realized these people have every opportunity to spread coronavirus, and they had to go back and train everyone. We always say, oh, we include everybody, but in this case, it's absolutely essential. So their day rooms are closed, dining rooms are closed, craft rooms are closed. Those tablets, yeah, very, very poor response from people with dementia. I think other people have really, really benefited from having visits by Zoom or whatever means that, whatever electronic means they're using. It's been good for the people who understand. How have they accommodated having absolutely no activity? You know, actually, when people are in a nursing home, week in and week out, every months, years, there need to be some activities. Well, that's difficult when people are isolated in their rooms. One of the ways they've accommodated is to have people come to their doorways. They stay 6 feet apart, but they can see other people. They can do sing-alongs, they can do some activities, they can bring activities into the room. The staff can move up and down the hallway, and so that at least they see a little bit of activity. Window visits have actually, for some of the people with dementia, been absolutely scary. When somebody bangs on their window, they cry and they retreat because they've been afraid. I saw a really, really interesting little photo of an enterprising nursing home where they brought ponies up to the windows so that the residents could see them. Now, we have some high-rise facilities, and it's not just in Florida. I don't know how they're doing these window visits. I guess they're moving people up and down elevators when you have a second and third floor. We always see people on the first floor, but we do see some waving from higher floors, but there aren't usually balconies on any of the resident rooms for safety reasons. And the nursing homes are now, they're learning how to stay in touch with the families. They are making weekly reports, sending them to the families so the families feel like they at least have some connection with their loved one in the facility. And some have opened up 24-hour hotlines so that you can call and ask at any time of day or night. You can see that these don't substitute for being with real people, but it's a help. So what have they had to do with their staff? Well, they found that some of the staff were ordering lunches, meals in, or bringing things and sharing. So what they're doing in some places is they're providing lunch out in the courtyard to keep staff at a safe distance from each other. Another thing that I wouldn't have thought of, but that some nursing homes had to grapple with, is that a lot of their staff, we have a lot of nurse aides who are paid minimum wage, may or may not even have a car that they can drive to work. So they're giving them gas money to drive so that they're not carpooling with other staff. You can't maintain distance in a car, unfortunately, which is why one of our studies, which is called Fit to Drive, in which we test people in an on-the-road test, isn't active right now, to our great frustration. And yes, they are assigning COVID recovered staff to their COVID unit. Of course, I don't think we know yet how long immunity lasts, but at least for now, it's a help. So one of the concerns for the people with dementia in these nursing homes, we have barely begun to think or talk about, is all of the collateral damage, other than the possibility of the infection and potential death from it. These are the most important items of collateral damage. And I expect 6 months, a year from now, we're going to be talking about these a lot. And we're going to be looking at how much has happened. Depression, and people with Alzheimer's disease can become very, very depressed. Weight loss, which is a problem in nursing homes if nutrition isn't adequate. Dehydration, which is another major problem. Older people need to stay well hydrated, or we're going to get more of those urinary tract infections. So one problem leads to another. Functional loss. Already they've had functional loss due to the dementia. And when we add that on top, because they haven't been able to get up and move around, Karen mentioned that I've done some work on exercise with nursing home residents. And that's one of the reasons we found that just mild walking exercise really made a big difference in their health and in their function. And cognitive decline, we may see more of an increase because there's so little stimulation, or stimulation that they can understand. Well, CMS and CDC have not been inactive. They have been very, very active, but some of their responses have raised some concerns. And I think the one that concerns my colleagues the most, especially those that are in quality improvement, is that CMS has placed a year-long waiver on any of their quality measures. They are focused only on response to the pandemic, and all the other quality measures, staffing, all of these other things that are usually, skin breakdown, all of those things that I've been mentioning before, they have a waiver on those. And a year is a long, long time. So this may actually inadvertently contribute to that collateral damage. Testing requirements. Some people feel that the mandate to test residents routinely should be put in place. Federal strike team. I'm not going to say that the federal strike teams are a concern. There are concerns of the nursing homes. The people in the quality improvement organizations, in some cases, have been told they're not allowed to be making visits, and so they're sending in agency nurses instead. And they're concerned about that because they're not sure that the quality of the intervention in these homes that have had spikes in their infection rate has been as good as it could be. But the federal strike teams are out, and I'm not sure that we've heard much on the news about that. So we've got a little bit of time left. Let's move out into the community. And this is a silent problem. You hear very, very little about what's going on in the community. We use two terms typically. One is formal caregiver, which is a person who's paid to provide assistance, whether at home, in a center, or in a nursing home. In Alzheimer's disease in particular, although it's true for some others, the informal caregiver is that critical unpaid family caregiver. They provide, and this is 2019 figures from the Alzheimer's Association, and I always look to say, did they really mean billion? 18.6 billion hours of assistance worth $244 billion. Well, imagine adding that to our Medicaid and Medicare bill. 18% of spousal caregivers, by the way, die before the person with dementia. We're very, very concerned about the burden placed on caregivers. I think this is a really good graphic on high to very high emotional stress. Look at that, 59% of the caregivers report that they have a great deal of emotional stress from caregiving. The physical stress isn't as high as even though they work very hard. And one of the first books about caring for a person with Alzheimer's disease was called The 36-Hour Day. And yes, they didn't lose count. It just feels like 36 hours in a day when you are on duty 24 hours a day. These are the subtopics at the bottom are all of the things that caregivers help their family member with: getting in and out of bed and chairs, feeding them, getting dressed, bathing, showering. Understand that people with dementia sometimes misunderstand what they're seeing or what's being done. And sometimes they become very, very resistive, even combative. And when you have a 6-foot-tall husband and a barely 5-foot-tall wife who's half his size and half his weight, she can have a lot of difficulty with that. It doesn't mean, I'm not saying that the men are more difficult though, because sometimes the women will look at the man and think there's somebody who's come in their house, does not recognize him, and calls the police and say, get this stranger out of my house. So being a caregiver for somebody with dementia is really difficult in the best of circumstances. And look at what we've got now. We have the challenge of infection control. Reports from my colleagues from other parts of the country tell me that there are home health agencies who only now really tackled teaching their aides really good, strict infection control. They hadn't been doing it before. Early in the pandemic, been told about, I know of one example where a physical therapist came in to provide post-discharge therapy to somebody who had had hip repair. They were not yet protecting themselves. They were not masked. You can't keep your distance with some of these things. You can't, as they say, phone this in. You have to put your hands on people. So you need to be prepared. The therapist was not masked, did not know that he or she had the coronavirus, and the patient caught it, and he was dead in 2 weeks. This is the family was devastated, and there was actually no excuse for this, except that they really weren't well prepared. Family caregivers too, they need to learn how to practice infection control for themselves. And PWD is not a very attractive abbreviation, but it means the person with dementia. The isolation and the loneliness that families with a person with dementia, family caregivers, have experienced during this 7 going on 8 months of isolation, of not maybe quarantine, but of social distancing, has just been acute. Respite services like the day centers, which would give family members a break, and the person with dementia stimulation, they would spend the day. We have a day center at on our own campus, the Memory Wellness Center. It's been closed, and they will open as soon as they can. And the person, when they've spent a day at a place like that, especially if they're as good as ours is, will go home tired and sleep well instead of staying up half the night. Support group meetings have been canceled because we can't get together. Simple outings that a lot of families have found really are exercise, they're pleasant activities, and it just has really a remarkable effect on the mood of the person with dementia. Lunch at a favorite diner. I knew one husband took his wife to the diner every day. He didn't cook, but he was the caregiver. And diner was closed. Now what? A walk on the beach, a walk in the park, walk in the neighborhood. Visits with family and friends even have been restricted. This has been really, really hard. This is just another list. Support services are unavailable. Day centers closed. Home assistance limited. Informal. Supports are restricted. Dental medical offices are closed except for emergencies. Even that trip to the barber or the hairdresser has been difficult. So we have come up with some solutions. We have not been totally without some ideas of how to help. Telehealth visits have made a big difference. People can consult. They can receive counseling, guidance. It has been a big help. Technology-assisted support groups have been a lifeline for many of the caregivers. Some of them are using telephone, others are using Zoom, WebEx, whatever is available, including at our center. And infection control training is going on, and it's critical, and we're still not done with that. Just a moment to talk about research opportunities, and then if you have some questions, I'd be happy to answer them. I think there are enormous opportunities for research here. There's so much that we really don't know, particularly about what's going on in the homes. Infection control for programs for family caregivers. People with dementia until the very, very end still have some ability to learn. Can we create a program to teach them how to do some of this infection control? Auxiliary personnel, those aides in homes, and as well as in facilities, they really need more training. Simplified, effective control programs. We need to develop ones that are easy for people to use. And I'm not even going to talk about the availability of tests and PPE and all that. You've heard that. The collateral damage, I think we need a lot of research. There are databases that can be accessed, like Casper, MDS, there's a few of them. The nursing home industry is highly regulated, and so there is quite a bit of data out there. Not always easy to understand and access, but it can be done. And we can look at what kinds of changes occurred in terms of mood disorders, communication, interaction, withdrawal, excess cognitive decline, excess functional decline, the nutritional status, and the health and illness status of these folks over this difficult time. Telehealth, we've just begun to develop telehealth as much as we can. We can do cognitive testing, we can do visual inspection consultations, we can look at test results and discuss them. But hands-on, it does require that we be in the same room together. Technology-assisted care, socialization. We can do counseling, we can do education, we can have support groups. We can do group activities. We can invite everybody to the same place at the same time virtually to do exercise, to have discussions, cognitive stimulation. We can do all of this. Have been talking with some colleagues about doing some research on this. And that is the end of my presentation. And I believe I should stop sharing my screen. I see Karen there.
Yes. Great, thank you very much, Ruth. Very interesting. Definitely hits home, given that my mom just got diagnosed with early stage Alzheimer's as well. I don't know if you know that, but one of our staff members actually created a program called Connected Through Caring, where her team writes cards, for example, and sends those to nursing homes, particularly during the time where they were really closed. But apart from that, as community members, is there anything that you could suggest that how we could help those who are in a nursing home, maybe isolated in their own room there and cannot really do or see anybody?
You know, it's really hard to help the people in the nursing homes. For a long, long time, you weren't even allowed to bring a package. I mean, now I think they've eased that. So I think visiting outside, they will gradually allow other people to come. I think maybe that, and of course, bringing things that they can see that, you know, could provide it. I was thinking about pet therapy. You know, there's so many places. Almost every home has trained therapy dogs and sometimes cats who come in, and we can't even do that during the pandemic. Mm-hmm. Everybody who pats the dog,
right?
You can't be patting the dog in between. Are they a likely vector? I don't think really, but we can't take the chance yet. You know, we need to test all of these things and figure out how we can do them. But I think in the community, we can run errands. If you have a neighbor who is isolated and can't go out because their person with dementia can't follow these rules. I mean, we had trouble at first, didn't we? And we can hardly wait to get rid of them, but we're doing them. But I think we can help people in the community. And yeah. I think that is something that we can do without putting ourselves at risk. just being able to get things, just being able to have conversation at a safe distance outdoors is something. That isolation, I think, really, even among people who don't have a problem with dementia, they're having problems with dementia. They said the rate of dementia is going way, way up.
Just to follow up on what we can do in the community, you mentioned that tablets and like the electronic, the technical interactions are often difficult for individuals with dementia. So you wouldn't suggest that like using an iPad or something like that to keep in touch and just chatting with somebody who has dementia in a nursing home would help?
You know, I think we can, but one of the things that we've learned about people with dementia is that what we call overlearned behaviors, things that we've done again and again and again. I mean, how many times have you, well, of course not, you haven't done it lately, have you driven into the parking lot at FAU and said, I hardly remember anything about getting here. It's such a routine for us. Okay, overlearned behaviors. We don't have to think about them a whole lot to do them. I think little by little we could gradually introduce them, but it's very difficult because the nursing homes don't have enough staff to do that. Over time, we'll figure out how to do it. And for the people who are very, very mild or don't have dementia, bringing, you know, laptops and tablets into the nursing home has been almost as important as is to help people, you know, in schools.
Mm-hmm.
You know, there are a lot of people who are low income who don't have internet access.
Absolutely, yeah.
Yeah.
Okay, another question. You mentioned that almost all nursing homes, the dining rooms, for example, are closed right now, and most of the inhabitants are staying in their rooms, in their own rooms, and can't really get out. The question here is, why that strict isolation? Why don't they try to implement social distancing but keep for example, the dining rooms open like they're doing now in the restaurants, right? Where you have the tables further apart. You cannot sit at this table because that's, you know, your social distancing table. Couldn't they do something like that in the nursing homes, or is it just because intrinsically it's the patients in the nursing homes are more at risk?
Well, look at the restaurants. The restaurants are said they're allowed to be 25%.
Mm-hmm.
You know, so that means 25% of your people can go to the dining room. And how do you choose them? Because one of the problems with testing, which is why we are all waiting so eagerly for a safe vaccine, is because we know when we get the test result that we were negative yesterday or last week or 2 weeks ago. We don't know how we are today.
Yep, absolutely true. Yes.
And you can't keep a mask on to eat.
Yep.
You have to remove your mask.
Yeah.
So I would think that they are going to gradually, and I think like with visiting, they're going to start moving people outside. Now, for people who live in northern regions, outside's not going to work real well come November.
Right.
For us, it'll actually be better. I mean, we have that advantage. We'll be able to use the outdoors, but a lot of those places, it's just too cold, and they're going to lose a little bit of that.
And that was actually one of the next questions here was about the outdoor time and the redesign, maybe using temporary setup, or, you know, that allows the social distancing, fresh air, scenery, less risky gatherings, maybe even for dining. What about if one person was allowed from the outside to come on a regular basis by appointment? Again, the difficulty is you don't know if that person is infectious, right? Even if you got tested yesterday, you may be infectious.
Yeah, you can't go by the testing, right?
Yeah.
But we can. I mean, people can be taught to use PPE. We're all learning gradually, you know, how to put a mask on correctly, what masks are effective and what aren't. Look at FAU people did some research on that. So we can teach people how to use gloves and gowns and masks and come in. And I think if this goes on too much longer, and it is still going on, I think we will probably start doing that, because they don't entirely forbid. You saw on my list that it did include volunteers. And as they open up gradually and carefully, they have to be so careful about it, because that's what happened in the beginning. Staff and visitors probably, they brought the disease into the nursing homes. They didn't know they were bringing it.
Mm,
And that's how nursing homes became our first petri dish, and
right.
lost a lot of people because of that. So they're going to proceed very, very carefully. This is a very high risk group because you're not in a nursing home unless you need a lot of help, unless you have a number. Some of them will have so many comorbidities. They're really 6, 7, 8. You would be surprised how many are on some of those charts.
Right. Um, you mentioned the use of dogs and cats in nursing homes, and that's difficult right now as well, of course, because you cannot sanitize the dogs or cats going from one person to the next. Now, I know that the College of Nursing, though, has a project where you use robotic cats, I believe, in nursing homes. Would that be an alternative to use? You could easier sanitize those, right?
Well, I think it would be easier if you gave one to each person.
Yes.
And, I mean, I don't like treating older people who are 80, 90. I don't like treating them like little kids and giving them baby dolls and things like that. But I don't see why we can't create robots.
Mm-hmm.
It could be robotic cats. That's a good start,
Mm-hmm.
because they are clearly robots. We've had a big argument about when a person is time confused. That's another thing that happens. They'll think their parents are still alive or something like that. That's part of the time confusion of advanced dementia. I don't think we should reinforce that, but yeah, I think there's a lot of possibilities for a lot of creative endeavors that we could do.
Now, you mentioned all these kind of collateral damage, like the depression that comes with our current situation, that we don't just only see in nursing homes, but I think across the nation overall. But what could family members do to prevent the long-term impacts that dementia patients who don't get COVID, but maybe suffer from some of the collateral damage have? So like the dementia patient that maybe have an increase now of depression or something like that.
Well, until they can, that's why I put down that one of the family's roles is being an advocate. Our legal requirements for staffing in nursing home are pretty slim. You can go to Nursing Home Compare, and you can look up any nursing home and find out how many minutes a day of RN, LPN, and aide time they are providing per person. Most of them are giving a fair amount of aide time, but the aides are expected to do a lot. They have enormous responsibilities. What can you do as a family member? You can make sure you get that weekly report. They owe that to you. I don't care how overwhelmed they do, and I think it's good that they put it in. Use the hotline, and as soon as you can and can do it safely, go and visit, because that's part of what you're doing as a family member. It's not just to see your loved one, but also to be sure that they're being well taken care of. I'm not that critical of nursing homes. They do a lot with this very small amount of money. Funding for nursing home stay, Medicaid funding, is very low.
Mm-hmm.
It's shockingly low.
Right.
Medicare's not bad. Medicaid is about 1/3 what Medicare pays. So, I mean, some of these problems that we've known about for a long time are going to come to the fore as we see how much collateral damage occurred.
Yeah. Okay, we have only time for one more question. I know we have more questions, so we will ask you to answer those offline, and then we put those together with the recording on our website. But my last question here is, would it help Alzheimer's patients or dementia patients to receive cards or letters from the community with words of encouragement? And is there anything else that you can think of that we as the community, coming back to that, can actually help and do and interact with nursing home inhabitants?
Yeah, I think because cards can be left to sit, coronavirus doesn't stay alive and viable for very long. So these are things that can be just, allowed to, I call it air. It's not really airing, but I mean, coronavirus does not survive on these things. So I would ask the nursing homes what volunteers could do. Don't forget, we really can do some group activities with everybody in their doorways. It's kind of hard to imagine, but people are sitting in their doorway, so there's adequate distance, and the person who's leading the discussion or providing some entertainment can be protected, masked, you know, to protect other people, masked and gloved and all of that. So yeah, I think as they open up gradually, there's going to be more and more we can do. And I think we're all, like I said, we're going to be really challenged to come up with some creative ways to bring that in. Doesn't sound like healthcare, does it? But when you're there, year in and year out, you need some of that as well as the medicines that we give out.
Great. Thank you so much, Ruth. It was a pleasure
My
having
pleasure.
you today. And we hope to see everyone again next week. Have a great rest of your day.
Bye-bye.